Hi guys, welcome to Radiology 365, where we try to cover core radiology from cover to cover. Today we are going to be talking about malignant hepatic masses. Now let's talk about a rare but fascinating variant of HCC, fibrolamellar hepatocellular carcinoma. This one breaks the mold a bit. Unlike conventional hepatocellular carcinoma, fibrolamellar HCC typically affects younger patients, often in their teens to their 30s, and notably without underlying cirrhosis or chronic liver disease. One thing to remember is AFP is usually not elevated in this, unlike in the normal hepatocellular carcinoma we've come to know that has elevated alpha fetoprotein. It's normal in this case, and so it can also help us make that distinction. Imaging wise, it usually presents as a large solitary mass with a central fibrotic scar, and fibrosis in MRI is T1 dark, T2 dark. But here's the catch: FNH, focal nodular hyperplasia, also has a central scar, but the scar in fibrolamellar is T2 hypointense, but in FNH it's T2 hyperintense. So this helps us distinguish between the two. Also, fibrolamellar lesions often lack a true capsule but may have a pseudo capsule when they compress or put pressure on the surrounding normal hepatocytes. So if you see a large liver mass in a young adult, especially without liver disease, you should be thinking more of fibrolamellar. So in these images, we have an axial CT, that's the top image, and it shows a heterogeneous lesion corresponding to a heterogeneous signal on this T2 weighted MRI in the middle here. And on post-contrast MRI, we see an area of hypercellular enhancing components within the mass, just a small area. Generally, it's largely non-enhancing, and there's also this rim-like enhancement here. This was a case of a fibrolamellar HCC. Then we have cholangiocarcinoma, which is the second most common primary liver malignancy. It has several forms, but today we're going to be focusing on the mass forming type, which is the most common subtype of cholangiocarcinoma. These tumors are usually large and lobulated, and the key imaging clue is delayed progressive enhancement due to their fibrous stroma. They don't light up on the arterial phase like hepatocellular carcinoma, and the delayed phase of imaging, which is usually 2 minutes post-contrast administration, usually might not even show enhancement, but you would have to wait about 10 minutes post-contrast administration to see the enhancement of these cholangiocarcinomas. Also, keep an eye out for associated biliary dilatation. It's not always there, but if it's there, it's a good indication that this is likely a cholangiocarcinoma. These tend to obstruct the bile ducts as they grow, so upstream dilatation is often a giveaway. In summary, if you see a large liver mass with delayed enhancement, like really delayed enhancement, and biliary obstruction, mass-forming cholangiocarcinoma should be high on your list. So these images show a large peripheral cholangiocarcinoma with heterogeneous, markedly hyperattenuating central enhancement in a 70-year-old woman. The first image is a CT scan obtained in the portal venous phase, and it shows a large, slightly lobulated heterogeneous mass involving the right hepatic lobe and the medial segment of the left hepatic lobe. There is no ductal dilatation here or lobar atrophy. This was a non-specific finding. And on the second image, 12 minutes post-contrast administration, we see delayed heterogeneous retention of contrast material within the tumor, which is markedly hyperattenuating. That's its attenuation is even higher than the attenuation of the blood vessels. This was a case of a mass-forming cholangiocarcinoma. Metastases are by far the most common malignant liver lesions, so always keep them in mind when you see liver masses, particularly in patients with a known primary cancer somewhere in the body. Most metastases are hypovascular, meaning they don't enhance early, so the portal venous phase is your best bet for detecting them. On MRI, they are typically T1 hypointense and T2 hyperintense. One particularly helpful ultrasound feature is the target sign. That's where you see a hypoechoic rim with a slightly more echogenic center. Remember, if you see multiple liver lesions, especially with varied appearance, metastases are the likeliest cause until proven otherwise, even more so than HCC in some cases. So in these images, the first one is an ultrasound and it shows innumerable target lesions pointed to by the arrows, and these are consistent with hepatic metastasis. And the CT of a different patient, by the way, shows multiple non-enhancing lesions in the portovenous phase in a patient who had colorectal cancer, suggestive of liver metastasis. Now let's break down metastasis a bit further, because not all mets have the same behavior. Hypovascular mets are the most common, and these come from primaries like breast, pancreas, lung, and lymphoma. Hypervascular mets stand out more and enhance early. When you see hypervascular mets, think more of melanoma, renal cell carcinoma, carcinoid or choriocarcinoma, and thyroid cancer. You can remember this by the mnemonic MRCT: melanoma, renal cell carcinoid, choriocarcinoma, and thyroid. Then calcified metastasis suggests mucinous tumors like colorectal or ovarian cancer, or even osteosarcoma. Lastly, cystic metastasis often come from ovarian tumors or GI carcinomas. These can mimic benign cysts, so context is crucial. So knowing the patient's history is half the battle. It can steer your interpretation significantly. Pseudocirrhosis is a term we use when the liver looks cirrhotic on imaging, with nodular contour and shrinkage, but it's not due to chronic liver disease. The most common scenario is a patient with treated liver metastasis, particularly from breast cancer. Over time, the fibrosis and scarring from chemotherapy can remodel the liver, mimicking cirrhosis. But here's the catch: even though it's not true cirrhosis, the complications of cirrhosis are real. You may have portal hypertension as a result of pseudocirrhosis. These patients can develop ascites and even varices. So if a patient with metastatic cancer develops signs of cirrhosis without a liver disease history, you should be thinking along the lines of pseudocirrhosis. So this image is a case of pseudocirrhosis due to multiple treated breast cancer metastasis. It's a contrast-enhanced CT which shows numerous hypoattenuating hepatic lesions with a markedly nodular external hepatic contour pointed to by these arrows that resembles cirrhosis. Liver function in this patient remained normal. Primary hepatic lymphoma is very rare and may present as a single mass or multiple masses. They tend to be infiltrative and preserve hepatic vasculature. Lymphomatous involvement of the liver tends to be secondary to systemic disease with associated splenomegaly and lymphadenopathy. On ultrasound, lymphoma tends to be hypoechoic and may have the target sign similar to metastasis. On CT and MRI, lymphoma is hypoenhancing and tends to show restricted diffusion on MRI. Now, these images show a PET CT and it demonstrates a single defined low density focus in the liver and a more diffuse low density change of the liver parenchyma itself. There is remarkable FDG avidity in this patient with biopsy proven hepatic lymphoma. So the lymphoma was very infiltrative and looked very diffuse, causing the diffuse low attenuation, but on FDG PETs, that's where we saw this marked avidity, telling us there was some disease in there. Post-transplant lymphoproliferative disorder is a rare type of lymphoproliferative disorder that can develop in organ transplant patients due to chronic immunosuppression. In liver transplants, this can manifest in the liver itself. The tough part is that the imaging is non-specific. Post-transplant lymphoproliferative disorder can look like almost anything: solitary mass, multiple nodules, diffuse infiltration. So I mean, from what we've mentioned, it sounds like it could be mistaken for regenerative nodules or mets or lymphoma. So history is very important. The clinical context is what will make you think of it. If a liver transplant patient develops new masses, particularly in the early years of post-transplant lymphoproliferative disorder must be considered. It's rare but critical to catch early, since reducing immunosuppression can be curative. Epithelioid hemangioendothelioma. It's a mouthful, I know. It's a rare vascular tumor that behaves somewhere between benign hemangiomas and aggressive angiosarcomas. It tends to present with multiple subcapsular nodules, often along the liver periphery. One key feature is the halo or target appearance on imaging. You might see rings of enhancement or signal change. It's also one of the few tumors that causes capsular retraction. That's when the liver surface gets pulled inward over the lesion, unlike in most tumors that tend to bulge outward. Sometimes you also see calcifications within the lesion. So if you see a subcapsular nodule with a halo appearance and retraction, especially in a younger adult, keep epithelioid hemangioendothelioma on your radar. So these images are multi-sequence MRI, and it shows multiple T1 hypointense and T2 hyperintense hepatic lesions with a peripheral target pattern enhancement pointed to by this arrow, and some capsular retraction, but this wasn't shown on these images. So this was a case of epithelioid hemangioendothelioma. Let's take a moment to talk about a really useful imaging clue, the capsular retraction that we have mentioned a bit throughout this presentation. Normally, masses push the liver capsule outward. So when you see the capsule pulled in, it should raise a red flag, and your differential isn't really that long. Cholangiocarcinoma is one, classically causes capsular retraction due to its fibrous nature. Fibrolamellar HCC also has fibrous tissue and may cause capsular retraction. Then epithelioid hemangioendothelioma, as we just discussed, often shows this as well. Pseudocirrhosis from treated metastasis causes widespread capsular irregularity and confluent fibrosis, which is a benign fibrotic area, usually in the medial left lobe or anterior right lobe. All right, so let's wrap things up. We've covered a lot, starting with how HCC develops in cirrhotic livers, how it can mimic or be mimicked by other nodules like dysplastic or regenerative ones. We talked about the imaging hallmarks of HCC, arterial enhancement, portal washouts, capsule, and how the LIRAT system helps us standardize our approach, especially for high-risk patients. Then we walked through the major differential diagnosis from fibrolamellar HCC to cholangiocarcinoma, metastases, lymphoma, and rare entities like EHE and PTLD. The key takeaways here: imaging is central to diagnosis, especially when biopsy is risky or not feasible. And knowing the vascularity and enhancement patterns of each lesion is what helps you narrow the differential and make confident calls. Thanks for sticking through. Next, we're going to be talking about benign liver masses. If you have found value from this, give it a like, comment, share to someone you think would love this, and I will see you in the next one.